So let me go ahead and introduce Doug as our first speaker. So Doug Diekema, who I mentioned before, is the Director of Education for our center. Doug has been here since 1991. He is trained as an emergency room physician. He is the chair of the IRB at Seattle Children's Hospital. As I mentioned, he's been responsible for organizing this conference for the last 7 years. Most recently, he has organized what will be probably one of the first of its kind, a casebook of pediatric bioethics cases, of 40 different cases, in which him and some colleagues have edited with around 50 contributors. So this should be an outstanding contribution. Unfortunately, it wasn't ready this year, but it'll be published in September. And so I encourage you to look for that on Amazon.com or your neighborhood bookstore. So with that, let me turn this over to Doug.
Thanks, Ben. Welcome. I want to welcome all of you from out of town as well to the beautiful Northwest. And Ben is right. This is looking to be probably one of our nice weekends of the summer so far. And most of you I know are coming from 100-degree, sweltering, humid temperatures. So it should be a nice break for you. The overall topic that we're addressing with our conference this year is the whole issue of children, their access to health care, and the many ways to think about that. And so I am going to address that issue from my own sort of perspective as not only an emergency room physician who takes care of children, but also somebody who thinks about bioethical issues. We all know most of the statistics on this slide. There are over 50 million Americans who are uninsured in the United States, and about a third of those are children. The figure, when you actually look at families who are underinsured, in other words, have insurance only part of the year, that number goes up significantly. We also know that our country in particular spends a great deal on health care. That number comes out to somewhere around $7,000 per capita. And we also know that insurance is outrageously expensive. Now, many of you may not actually know that because it's provided through your employers. But unfortunately, more and more Americans every year are learning just how expensive insurance is as their employers cut coverage or drop coverage or as they become unemployed. And those figures really need to be put in the context of what the average American earns. As a general, the figures up here are actually several years out of date, so they're higher now. But as a general rule, the cost of insurance for a family of four for the average American takes up about 20% of their income, which is a substantial percentage, and for many families is beyond their means. I want to make one initial observation before I launch into the primary things I want to talk about, and that is that this issue of uninsured persons and the cost of health care is not simply an economic one, it is an ethical one. And I think focusing exclusively on this as an economic question distracts from the real issue. Whereas the economic issue is really about how we're going to pay for health care, the moral issue is whether we're going to pay and who's going to pay and what the limits will be. And I'm going to try to address those three things to a small degree. And I'm going to really ask three questions this morning. First, do children have a valid claim to the provision of health care? Secondly, if they do, whose responsibility is it to assure that they receive care? And finally, are there limits to what they can expect us to provide or someone to provide to them? So the first question, do children have a valid claim to the provision of health care? As a general rule, there are probably two philosophical groundings for this claim that someone, in this case children, might have a valid claim to health care. The first is, I think, the more difficult argument to make, and that is that it's rooted in justice or fairness. And the second, which I think is a little easier to make, is it's rooted in a notion of social beneficence. In other words, that a good society, a group of people that takes their responsibility to others seriously, which is essentially what beneficence is, will assure that certain basic needs are taken care of for all members of that community. Now, to a certain extent, justice and social beneficence reflect community values. In other words, it's difficult to make a completely objective argument that anybody owes anything to anybody, but most of these arguments do reflect community values, and I'm going to build on that as I talk about what I think Americans really believe. This is just that sort of notion that not only does justice, for example, reflect community values, but also to a certain extent individual values. It often really depends, how you feel about justice often depends on where you sit in the scale of how much stuff you have. This is actually off a Starbucks cup, but it illustrates it nicely. Now, to get at this, I want to tell you a story about a federal regulation that I'm very familiar with. It's known as the Emergency Medical Treatment and Active Labor Act. Many people call this the federal anti-dumping law. And it was passed 15 years ago to address, or 25 years ago, to address the problem of patient dumping, the denial of care or the transfer of patients from one hospital to another because those patients couldn't afford the cost of care. It was economic triage that was going on. And in 1985, Congress passed this law to address that problem, and it was signed by Ronald Reagan in 1986. The purpose was to prevent the transfer of unstable patients for economic reasons. Now, why did this law come into being? Prior to 1980, as a general rule, providers and institutions provided a fair amount of charity care, and they did so in many cases out of a sense of what Uwe Reinhardt referred to as noblesse oblige, but it was also a sense of that there was some obligation of them to provide for the needs of those who didn't have insurance. And hospitals and providers largely were able to afford to do this by doing something which has more or less gone out of vogue, which is known as cost shifting. In other words, what they would do is that for paying patients and those covered for insurance, they would charge a little more than what the care cost, so that they could then provide care to people who didn't have insurance. So it was in many ways sort of an unofficial way of insuring the uninsured. What happened in the 80s, however, was that several things started to change. Healthcare costs started increasing fairly alarmingly. Reimbursement rates started to decrease. Insurance companies became fairly savvy about the fact that cost shifting was going on and started refusing to allow cost shifting. They started placing limits on what they would reimburse for care. And sort of the whole concept of a hospital sending a bill and that bill being paid changed to one where the hospital sent a bill and whoever was paying ignored the bill and paid them whatever it was that they had sort of contractually agreed to pay at some point in the past. The other thing that changed was that healthcare became much more of a for-profit industry. And this is not to say that healthcare wasn't for-profit before, but it is to say that there was clearly a change in sort of the overall context of healthcare, with it becoming much more big business, much more oriented toward profit and shareholders, and with those things becoming important. Many nonprofit hospitals being bought up by profit-making chains, and many nonprofit hospitals beginning to look a whole lot more like for-profit hospitals in the way they did business. So the bottom line was this reduced the ability to cost shift, and it also then reduced the ability of providers and hospitals to actually be able to afford to take care of those who could not afford health care. The existence of public institutions for those without insurance also helped minimize this sense of duty. So what you had was hospitals that were not the public hospitals starting to refuse patients and sending them across the road to places like Cook County and Harborview, hospitals that were publicly funded and had some sense of an obligation. This is a quote from one of the vice presidents of a for-profit hospital chain. "We don't expect Safeway or A&P to give away free food for people who can't afford it," the implication being that we don't have an obligation to provide free care. And this is the sort of shift in attitude you see as healthcare becomes more of an industry and a business than some kind of a mission. So what happened in the early 80s is that this notion of dumping started becoming epidemic. At Cook County Hospital over that 5-year period, we saw a 5-fold increase in the number of patients who ended up at Cook County because they had been turned away at other hospitals in the Chicago area. 98% of those were black or Hispanic, 81% were unemployed, and 87% did not have adequate insurance. In other words, these transfers were largely being done not for the good of the patient, not because there was some medical need that the hospital doing the turning away couldn't meet, but rather because there was an economic issue. And this graphically sort of shows you the situation in DC, Dallas, and Chicago between 1980 and 1985, when the number of patient cases of dumping significantly increased. So Congress passed this law. They saw this problem. They said, we need to stop this, and they did so by passing the Emergency Medical Treatment and Active Labor Act. I'm not going to go into the details of the law, which are fairly complex, but suffice it to say that the law basically says that when a patient presents to a hospital with an emergency room, that hospital has an absolute obligation to screen that patient, and the purpose of the screening examination, and in some cases labs and x-rays fit into that screening obligation, is to determine whether the patient has an emergency medical condition or active labor. If they have either of those two things, there is then an obligation to treat the patient to the point of stability where they can either be transferred stably or they can be sent home without some risk to the patient. A fairly substantial obligation. The interesting thing about EMTALA is that it actually provides essentially the only form of health care that can't be refused in the US today. I'm always sort of semi-irritated, at the same time semi-entertained, when I'm on bioethics blogs talking about whether there's a right to health care in the United States, and there's always at least one poster who points out that there is a right to health care in the United States, and it's EMTALA, it's the Emergency Medical Treatment and Active Labor Act, that anybody can show up in an ER and they can't be refused at least an examination to the point of making sure they don't have some emergency medical condition. The unfortunate side of EMTALA is that it essentially represents unreimbursed care and has placed a great burden on many hospitals. This led to the closing of about 10% of emergency departments around the country in the years following its passage. Hospitals looking at their financial bottom line, deciding one of two things: either the ER was going to put them out of business, or if it wasn't going to put them out of business, it was cutting into their profits to the point where it was no longer worth keeping open. So we actually saw a substantial loss in the number of ERs across the country. This in turn, in combination with the fact that now people knew they could show up in an ER and get seen, led to the current problem we have with emergency rooms, which is that they're severely overcrowded. It's become difficult to take care of people with true emergencies because there are so many people in the hallways and the lobbies and so on, and there's just not an ability to see them in a timely fashion and stabilize them. There are also some very perverse implications to this law. If you have diabetes, for example, and you can't afford your insulin, nobody has any obligation to provide you with that insulin. However, if you show up in an ER and you are now in diabetic ketoacidosis, we need to stabilize you, and presumably stabilization will mean at least giving you enough insulin to get you through the next week or so. At which point you'll be back in the ER with diabetic ketoacidosis. And there are many diseases for which this is sort of the issue. If you have chronic renal failure, the point at which you need dialysis is sort of the point at which your condition becomes an emergency, and suddenly you would be able to get in and be seen for that sort of thing. So this is not ideal care, but this is the sort of one right to health care that exists in this country. Now, if we sort of take a step back and think about whether there's a right to health care, there are different ways that people have thought about this. And one argument people make when they talk about whether there's philosophically a right to health care is they will make the argument that something like medicine should be distributed on the basis of need. In other words, those who need it the most should be those who are able to get it. And that medicine is something that should be distributed on that basis. Well, now notice that that does require that somebody pay for that care if you truly believe that that's a right. And EMTALA seems to suggest that at least the legislature and the people screaming at the legislature about the problem of patient dumping believed that patients, at least in need of emergency care, should not be denied that. In other words, there is a right to health care, and it was unjust that people were being transferred to different hospitals. Now, the situation in Texas was an interesting one because Texas, the problem of dumping was probably one of the largest in Texas, or at least the most publicized. And there were cases of women in active labor who, in some cases, visited more than a dozen emergency rooms in an ambulance, being turned away before they could get out of the ambulance at every one of them, ending up delivering on the side of a rural road on the way to the 13th or 14th hospital. So this was a real problem and clearly perceived not to be appropriate on the part of many people. There are others who argue that fair opportunity might be a better way to look at the question of justice. In other words, it's not unfair that Bill Gates has more money than I do, or that I have more money than some of you do. But what is unfair is if I have more opportunity to sort of put myself in a position to have health care and other things, and that everybody ought to have sort of some fair opportunity to optimize their welfare. That argument is the strongest in children in terms of optimizing children's ability to become adults that at least have the capacity to make decisions for themselves and optimize their economic welfare and so on. And then others have argued, along with John Rawls, that justice should be determined, and I'm going to make this very simple, so those of you who are philosophers don't jump all over me for simplifying this. But basically what Rawls said was what constitutes fairness is if you somehow can blind yourself to your own situation within a community, in other words, you don't know if you're the best off or the worst off, and then you would decide how you would structure society. In other words, you're behind this veil of ignorance. You don't know where you're going to stand in society. And many people would argue that behind the veil of ignorance, most of us would argue that we would want to make sure, above all else, or above many things anyway, that we at least had access to health care, whether we were the poorest person in that community or the most wealthy in that community. And that we would be willing, behind that veil of ignorance, not knowing where we'd be, we would be willing to say, well, even if I'm the richest person, I'm willing to sort of pay some money so that if I end up not being the wealthiest person, I still have health care access. So those are sort of three ways to think about this right. The story of EMTALA, however, seems very clear that people in the United States felt that there is some kind of a right to health care. They felt strongly enough to legislate that. And one of the interesting things about the legislative history is that many of the strongest advocates, and actually the author of EMTALA, were some of the most conservative, some of the most pro-free market people in the legislature. In other words, this was not a sort of liberal law. This was a law passed by people who ordinarily their ideology is to support the free market, to minimize taxes, et cetera, et cetera. So whose responsibility is it to assure that children receive health care? If we assume that the lesson of EMTALA and other arguments fly, that there is some kind of a right, at least to basic health care, who has that obligation? And I'm going to go back to the Emergency Medical Treatment and Active Labor Act, because this was essentially what EMTALA was. It was a congressional solution to the problem of lack of access to health care to those who didn't have health insurance. But I would also argue that it was a cop-out. Because basically what people said was, this is an outrage, this is a moral outrage, people are being left to have their babies in the street, they're dying outside of emergency room doors from gunshot wounds because they're uninsured. Somebody has to bear responsibility. But then if you look at the law, it's very clear that the third message was, but it's not us, it's the hospitals. In other words, we can't tolerate people not having health care, but we're sure not going to pay for it, was the message of EMTALA. Now, what I want to argue is that these views are incompatible. Regardless of which side of this debate you sit on, whether you sit on the side that says, well, we don't have an obligation as a society to pay for this, or whether you're on the side that thinks we do, I think the most important thing is to recognize that you need to own up to the consequences of whichever side you believe. I don't believe that it's compatible to hold, first of all, this first view, that no person should be denied medical or emergency care, and the second one, that the goods of the US healthcare system should be distributed according to a free market economy. As Ed Pellegrino has pointed out, in the free market, there is no place for those without capital, for those without money, for the poor. A free market is designed to operate with capital, and if you don't have capital, you basically don't participate. The means to purchase health care should not be guaranteed to all citizens via funding with tax revenues. Now, there are many people in this country who hold all three of these views. They will say, nobody should be denied medical care, health care should be distributed according to the free market, but taxes shouldn't pay for it. My point is that it's not compatible. You can't hold those three views. Now, I think you know what view I hold. I hold the first, that people should not be denied at least essential medical care. I'm willing to own up to the consequences of that, which is to recognize that that probably means an increase in taxes. That probably means somebody will take home a little less pay. And I think there are ways to deal with that that minimizes sort of the impact on society and the economy as a whole. However, what I would like to see is the people who disagree with that, in other words, people who believe that health care should be distributed to the free market and that the purchase of health care should not be via taxes, to own up to the consequence of that view, which quite frankly is that you have to be comfortable with people not getting health care, which means you have to be comfortable with people having their babies on the side of a road, and you have to be comfortable with people dying outside of emergency rooms of gunshot wounds. If you're comfortable with that, then there is some consistency in your view. If you're not, then you need to revisit those views. So let's look at this notion of social beneficence, because basically what people are saying when they say that there's something morally wrong about people not having access to necessary health care, is they're basically saying that there's some kind of an obligation we have as a community to look after those people. And we feel this way about other things. Many of us feel there is an obligation to protect the vulnerable. Part of the purpose, for example, of child abuse laws is to protect children who are vulnerable and can't protect themselves. Most people also agree that there should be some sort of universal community way to pay for threats, for common threats, like defense and police and fire and the control of pollution and the contamination of the food source and so on and so on. Those are very difficult things to do within a free market system because, again, if you decide that you're going to pay that only those who can afford it will get police coverage, you now have a society where some people don't have the advantage of having police. Earlier this year, we saw this played out a little bit. I believe it was in Tennessee, where the fire department showed up at a fire, and on their way to the fire, they discovered that the person who they were responding to had not paid their fire tax that year. And so the fire department basically pulled up and watched the house burn down. This created a sense of outrage within the community, which was fascinating. Because again, it's sort of this notion that it's just not okay. You have somebody whose house is burning down, you need to do something about that. And yet there also needs to be a recognition then that there needs to be a way to pay for that. And ideally, since everybody is at risk of having their house burned down, the way to do this, if you're not going to tolerate some people having their houses burned down, is you need to pay for it communally, and that means a tax-based system. And that's essentially what taxes are designed to pay for, is these sort of communal needs. I would argue that health care comes closer to crime and the control of contagion and starvation and water deprivation and fire than it does to things like iPads and SUVs and Mariners games, which I'm quite comfortable being distributed according to sort of standard free market principles. US policy reflects an individualism that isn't tolerated by most of its population. In other words, the ideology that we often hear talked about, that the free market rules and everything should be distributed that way, actually does not accord to the sort of common sense that people have of outrage when people are deprived of certain goods. And again, most of us don't get outraged when we find out that the person down the street from us can't afford an iPad or can't afford to go to a Mariners game. But we do get outraged, most of us, if their house burns down because they couldn't afford to pay for the fire protection, or because the police didn't respond because it's now privatized. Most of us would feel a sense of outrage about that. And so I would argue that common goods simply can't be left to sort of a totally free market. And leaving common goods like defense and healthcare and roads and national parks to the free market, basically rejects community goods and values, and it also rejects those individuals who don't have the means to pay. So are there any limits? I think you know where I stand on this. I think there is some obligation to provide health care to those who need it. I also think that the way to pay for that is communally. Are there any limits to health care? And I would say to that, that's the scope of that right, and I would argue that there is. It can't apply to everything. Recognizing a right to health care doesn't require recognizing a right to all available medical treatment. And every society limits health care, including our own. Some more than others and some more fairly than others. The question should never be whether to place limits, but what principles should be used to distribute limited resources. And I don't have sufficient time in this talk to actually address that difficult question. Some of our speakers may be addressing that question later in the day. But nonetheless, that's what the question is. It's not whether to place limits. I think a starting place would be to identify a decent minimum. EMTALA clearly identified a floor that nobody was, or very few people felt was anybody should be denied, and that was this notion of emergency care, a condition that actually threatened somebody's life, threatened somebody's limb, or threatened to have them having a baby without medical care. What about multiple tiers? I will just say that I think it's fine to have more than one tier. In other words, I think it's fine for a society to say we will provide a decent minimum of health care for all citizens. Beyond that, people will have to pay for their own, as long as that decent minimum is truly one that's acceptable to people. And I think this sense of outrage people have when they hear stories about people who were denied important medical care is a place to start in terms of where society stands on where that minimum should be. So some common objections to a single-payer or government-sponsored healthcare system, because that's essentially what I'm talking about. And I just want to point out before I do this that the common phrase you hear from people who disagree with my view is government-run healthcare. And there is a difference between government-funded healthcare and government-run healthcare. It's true that the payer often has a lot to say about healthcare will be delivered, but the two are not the same, and it's important to recognize that. So here's a common argument I hear: government-run healthcare is bad. Well, why? You need to recognize that this is not an argument. This is an ideology. Presumably, the objection here is that the government would screw it up. But again, there's no real good data for this. There are lots of government programs that are quite well run. I continue to be amazed by the post office. For less than 50 cents, I can put a letter in the mail, and it will get across the country in 2 days. And I have to say, I don't have the experience in the last 20 years of having had a piece of mail get lost in the mail. I mean, it's an incredibly reliable system. It's unbelievably inexpensive, and it's run by the government. It's widely acclaimed that the best healthcare system in the United States is the VA system. Guess what? It's run by the government. It's also one of the least expensive. So this argument that somehow government is bad, really, if you make that argument, you need to be able to define what you're talking about, because it's not clear that the data is there to support that necessarily. Does the government screw some things up? They sure do. Does private industry screw some things up? They sure do. All you need to do is look at our current economic situation and look at the roots of that with Wall Street and what happened there, and you recognize that the free market system is no guarantee that things are going to work out for the best of the community. Government-paid health care will lead to rationing, and that's my answer. Yep, but so what? I mean, of course it will. We ration now. Insurance companies ration. And if you haven't had that experience, I'd like to know what your insurance company is. So the real question here is, who do you want doing the rationing? The government that at least is supposed to be responsive to citizens, or a bureaucrat working for an insurance company whose primary responsibility, quite frankly, is not to you, it's to their shareholders, if they're a private corporation. We already ration, and we do it in lots of different ways. We do it by insurance status, we do it through deductibles and copays, we do it through exclusions for pre-existing conditions, waiting times for certain services, shortened hospital stays. There are lots of ways we already ration. This is just this is an argument people throw out there because they think it will convince you that government-run healthcare is wrong, but the bottom line is that it's no different than what we're already doing. It's just a different way of rationing. And rationing is going to be essential if you're going to control healthcare costs. The free market's the most efficient way to deliver healthcare. Well, I would argue there's no real data to support this view. It may be that the free market is the most efficient way to distribute iPads and Chevrolets and Oreo cookies and things like that. It's not clear to me that it's the most efficient way to distribute healthcare. There are some things that make healthcare fairly different than other goods. The first of which is you don't know when you're going to need it. And it's not the kind of thing that most people buy because they want it. Most people buy it because they need it, which sets it apart from iPads. I know some of you think you need an iPad and you need Oreo cookies. But the bottom line is you want those things. You're not, when I go to the doctor, it's rarely because I actually want to. I don't like going to the doctor, even though I am a doctor. And I'm going because I think there's actually something wrong with me. Or because somebody thinks there's something wrong with me, and that happens a lot. So it's a different sort of good, and it's not the kind of thing that most people are going to sort of purchase ahead of time because most people are fairly optimistic about their need for something that they might need in the future. There's other evidence that this is just simply not the case. I mean, administrative costs in the current system in the US are higher compared to almost any other country. Somewhere between 25% and 30% of the healthcare dollar is spent on administrative overhead. And if you compare that to Canada, it's more like 5 to 10%. That suggests there's a lot of waste and inefficiency in the system. Profit increases costs over nonprofit. And so if you talk about the costs of healthcare, having for-profit healthcare is not likely to actually cut the cost of healthcare because there's profit built in. And it's fairly substantial in the healthcare sector. Marketing, billing, executive compensation, risk stratification, all of those things cost money, and all of those things are necessitated by a private market. Profit maximization leads to perverse incentives in healthcare, I would argue, and decision-making leading to waste, and it leads to decision-making that actually increases waste and bad choices. And I look at the Seattle market, and I can see this all the time. Everybody is trying to get into the high revenue areas of healthcare, which means that you lose the efficiency of having, for instance, one heart center in a city, because everybody needs a heart center, because as it turns out, that's where you make your money if you're a hospital. And so you have everybody with a heart center. Now, what is a heart center going to do when it needs to generate revenue? It's going to create a need for patients, and you do that by finding people who need a heart center who maybe you wouldn't have felt that way if you only had one heart center in the city. So the bottom line is a for-profit company, the best way to increase your bottom line is to increase your market share. And if we're talking about solving a problem where healthcare costs are rising exponentially, it's not clear to me how leaving that up to the free market will do it, because the free market will try to expand the market. It doesn't try to minimize the market. And that means finding more patients with more conditions. By the way, you see the pharmaceutical companies doing this all the time. Most people don't realize it's the pharmaceutical companies that are behind it, but many of the sort of current conditions that are being treated with drugs were created by pharmaceutical companies. Shyness has now become a social disorder. Being short has become a social disorder that now needs treatment with growth hormone at a cost of $50,000 a year. And there are lots of other situations where what used to be sort of within the normal range of human functioning is now considered to be a disease that needs treatment with a drug. Pharmaceutical companies have largely driven that. Socialized healthcare is bad. Well, there are two arguments to this argument, or this problem. We already have a significant portion of our healthcare system socialized. It's called Medicare, Medicaid, and the VA system. Nearly all of my uncles are proponents of the free market healthcare system, and they always are on their soapboxes talking about socialized medicine. And I will say to them, well, you know, Uncle Carl, where do you get your healthcare? I mean, who pays for your healthcare? Oh, I'm on Medicare. It's like, do you realize that's socialized medicine? The bottom line is we have socialized medicine, and a lot of the people who don't like socialized medicine, who get socialized medicine, actually like their socialized medicine, like my uncles. Simply labeling something as socialized is not an argument. You have to tell me what's wrong with this sort of notion of socialized healthcare in order to make this a valid argument. This is going to lead to lines like they have in Canada. And the question I have here is, where do you get your health care? I called for an appointment at a dermatologist the other day, and it's 3 months before I can get in. Probably because they're doing an awful lot of injections with Botox. But the bottom line is that I have to wait in line all the time for my health care. And it's not clear how these lines are only happening in Canada and they're not happening in the US, because when I try to get patients into clinics, it can be a 2-3 week wait, sometimes a 3-month wait. We have the same problem here. We also have waits in ERs and for CT scans and lots of other things. All of these arguments basically avoid the larger issue, and that is that we have to decide what level of public support we're going to provide for health care and what level all children deserve, and what's the best system to accomplish that. 2 final observations. Gilligan's Island used to be my favorite show as a kid, and I always wondered the same thing. If the professor can make a microwave out of Gilligan's hat, why can't he just fix the boat? So 2 final observations. Taxes and health care. The notion that government spending is bad reflects ideology, but not much else. And there are examples where government clearly isn't bad. I mean, it accounts for a significant amount of the employment, for example. If we eliminated government in Washington state tomorrow, which would make some people happy, we'd lose 30% of the jobs in the state, which would make an awful lot of people unhappy. Public infrastructure is provided by the government. Social Security is provided by the government. There are good things government does. And remember, government is just us. We, the people, is the government. It's the community, and it's the sense that the community owes certain things to all of its citizens. There's a social benefit to having a healthy population, and everybody gets something in return. In my mind, the best use of taxes is when you're paying for something that everybody benefits from. National parks, a nationalized road system, healthcare. The final observation is one that Cornelius Planning has actually made in his book, Not the Way It's Supposed to Be. And Planning has pointed out that there are 2 kinds of human wrongs. The kind we always focus on, which he describes as a tax, that's like murder and robbing and that kind of thing. And then the kind we frequently don't realize are human wrongs, and that's what he calls flight. And what he means by flight is that we flee from our responsibilities. And that's what EMTALA was. It was an example of this notion of a moral wrong of flight. Rather than dealing with the real issue, which was uninsured patients, Congress simply mandated universal access and then sidestepped the issue of paying for it. They fled from their real responsibility in this situation. And here's a quote from Pete Stark, who was one of the advocates for EMTALA. Patient dumping is but a symptom of a much larger problem. 37 million Americans at that time are without health insurance. Low-income sick people are finding it increasingly difficult to get needed health care. So he's right on up to that point. And the burden of caring for them is falling on fewer and fewer hospitals. What I want you to notice is the last sentence tells you what Pete Stark feels, which is that this isn't my responsibility, it's the hospital's responsibility. And that's where he fled from his own responsibilities as a representative. So I'm going to leave you with a quote from Franklin Delano Roosevelt. The test of our progress is not whether we add more to the abundance of those who have much, but it's whether we provide enough for those who have too little. Thank you.